All right. Well, welcome again, everyone. And Angie, I'll turn it over to you.
All right. So go ahead and go to the next slide. So I am one of those people that has bandwidth issues, and so I'm calling in from my cell phone, and God love Andy, he is running the slide deck for us. Today we're going to talk about data analysis, and as soon as people say data, don't you feel them just cringe, whether it's in the email or the phone call, and they're thinking, oh, I got to report more. So hopefully we'll come up with some really good collaborative ideas with everybody. So we'll go to the next slide. We're going to look at a review of data analysis, very, very high level. We're not going to get into statistics. That's not what this is about. This is really looking at, what kind of data can we collect? And then a little bit about data mining. And when I think about data mining, I used to always think, oh, that's, total Excel, running pivot charts and all of this other stuff. It's easier than you think, but we just got to get there and make the right tools to get there. And then we're going to definitely be using, I just pulled out various pieces in everybody's work plans that were shared, and we're going to talk about them. So today is your day because you guys get to talk. And we're going to, kind of talk about your frustrations, your challenges. And then when I do my one-on-one calls next week, as well as that final week, we're really going to kind of bring it all together. So we'll go to the next slide. All right, data analysis, the prep work. When you get that NCC, it says, okay, complete your form, and what are you going to collect, and how are you going to collect it, and what is your outcome? We think about the full evaluation of our program, but we also recognize that we have some data prep to do. So when we start thinking about data prep, is the data truly accessible? When we start thinking about what am I going to collect and how am I going to collect it, or is it something that I'm going to get from another source? And I'll do it on the sidelines and not have the hospitals submitting any data. Looking at the electronic health record, I know in our pre-survey of questions, that was also recognized. They're not data friendly. We know that. And then, oh yeah, pay another $10,000 and we'll create this way of capturing your data for you. Well, nobody wants to do that. Looking at descriptive stats. And what I mean by this, and it's not a stats course, it's what do we want to get? A count, number of people that got trained, or is it an average that we're looking for, looking at our best practices, or is it a percent like in HCAHPS, that percentage of what we're looking at? How will hospitals report the data? If we are looking at capturing some data from everybody, how are we going to collect that? And we're going to talk about that a little bit later here. And then are you providing that template for data collection? We'll go to the next slide. And we're going to talk about that in a minute as well. So data mining, when we think about data mining, it's really used to discover new information about your data. I don't want people to think about data mining as this whole system of software and things you have to have. I need to know my T-score and my R value and all of that. No, it's really looking at the encompassing data that we have and what can we do with that data. It can be used for describing or predicting outcomes. And a lot of this, we can look at trends. And when you see later on in this, there's a slide and it talks about where we can get some of our data. When we think about data mining, those are great background baseline data points to help us in predicting future outcomes and what we want to look at from everybody. So we'll go to the next slide. So on our toolkits, and I know everybody, gets inundated, and the Rural Resource Center, and Task and Flex, and, there's so many places to go. Well, this toolkit, and I believe that you can see the link up there in the line, it is amazing. It really has a data use file, and we're going to look at several components of that, putting data to use and what we want to know about this. And we'll go to the next slide. But, let's look at it. What does it really give us? And this is where, as we start looking at data, it can get a little frustrating. So for example, we selected data use and then we went in and here's some data that just immediately comes in as soon as you click that box. It says measure data, unplanned hospital visits by state. And then you click on that and it's really not user friendly. So then it says download the CSV. Well, if you're not CSV savvy, you will see it as it is on that right-hand box. And what you need to do is then convert it over to an Excel file so you can actually manipulate the data and look at it, moving forward. CSV is not fun to play with. For those of you that have, been looking at data for a long time, you probably recognize that as well. So next slide. So what do we know? Data reporting is burdensome. COVID just totally took a tank for us in getting data and getting people to actually send things. And then we know we don't know where to really get the data, when we look at it. We know MBQIP has data. We also know the frustrations of MBQIP because it's old data. Outside of EDTC, all the rest of the data is dated, so it's a good baseline, but it doesn't really give us real-time data. Looking at some collaborative approaches on how we can capture some data. And then, I read in some of our work plans and some of the questions on our pre-survey, there was no request for some performance data. We know Flex Monitoring Team gives us data, Care Compare gives us data, Campus has data, and then obviously our hospital is doing some self-reported data along the way. But again, a lot of this data is dated, so how can we demonstrate over a year's time that we made a difference when we don't have anything to show for it? Because take example, let's say we start January to December, and I know this isn't the grant period time. So in January, we may have a year ago's data available on public report. When we get to December, we may only have first quarter data from that year, if we're lucky. And that's when we were just starting any projects. And so it's not going to show value of what we've done over the course of the year. So we have to look at ways to really capture something meaningful to demonstrate that the SHIP grants, truly are making a difference for our hospitals and how we capture that moving forward. The next slide. All right, so we got a couple poll questions here. And they're two very simple poll questions. Do you provide data tracking tools to your awardees? And or do you provide a platform for data reporting on quality intervals? And there's no right or wrong to any of this. This is the only two poll questions you're going to get.
I'll leave it open for about 10 more seconds and get your answers in.
All right. So most of us don't, supply any kind of a tracking tool or any kind of a platform for reporting. So, and that's okay. So what I want to know is how, the best way is to capture this data moving forward. And we're going to kind of get into that as we go along. But we use a project charter with examples and instructions for figuring out what to measure. Great. So what I have learned over the years, if I don't give folks a way to send me information on a timeline, I won't get it. That is a big frustration. And I know they hate the nagging, but they do eventually kind of drink the Kool-Aid and send data. So, we do want to look at that and say, okay, here is a tracking tool I want you to use, or a platform to send us some data on a quarterly basis. so we can start evaluating the use of the SHIP funds and what it's doing internally at that hospital. So go to the next slide. And you can take the polls thing off. There we go. All right. HCAHPS. This is probably one of our biggest ones that I've seen on everybody's work plans as far as what we're doing. And, you know, I do know HCAHPS is definitely a challenge for everybody right now in looking at our just getting data, you know, and meeting that mark for care compare, as well as looking at, you know, what are our hospitals really doing with their HCAHPS scores? So what data are the hospitals providing to demonstrate outcomes for you guys? And that's what we're going to get into here in just a second. So think about that as we go through this. Next slide. All right. We go on Care Compare, used to be Hospital Compare. Here's the data portal. This is the same data that comes out on our MB-QIP reports. It's older data. This is fourth quarter 2019 that is currently publicly reported. I have two hospitals here. They're both critical access hospitals, and they're right next door to me. So that's truly those two. Nobody's in this consortium. So what you see is, you know, there's star ratings for the overall star rating, and then there's that patient survey rating, and you can see the first one doesn't have any stars, and the second one has a 5-star. And what happened was the OSF one, now I also know a little bit about both of these hospitals, but OSF did not have enough surveys, you know, for publication to create a star rating. You'll see on the right-hand column, same two hospitals, if we scroll down, just looked at some of their data points. They have data, you know, which is good. You can see patients who are reported that their nurses always communicated well. 84% of the OSF hospital versus Hingham & Henry, 87%, you know, and then 85 and 88 collectively. But there's that little 6 there. And 6 just says that they had less than 100 reported, so they couldn't have an overall star rating. That doesn't mean the quality of care is technically lower. And so we have to look at other avenues to collect data because 1, this is older data, and 2, we have low volume data, you know, when we look at this. And so we have to think about what are we really wanting to get from HCAHPS and from the HCAHPS scores to improve with our SHIP funding. You know, just because they have a vendor you can see doesn't mean that they're going to have data to report. You know, they may still have very low volumes. So we have to look at alternatives of how to capture some of that data. Next slide. All right, so here's some things, and we're going to start discussion now, and you can use your chat box or jump on, unmute yourselves and talk. These are 2 different ones that we received. Thank you very much for everybody that submitted. And these were in regards to HCAHPS. So when we think about HCAHPS, we're thinking about where's the data coming from? Do I want a number? Do I want a percent? Do I want an average? You know, what is meaningful to demonstrate the quality of care in our small rural hospitals for them to be providers of choice, you know, for their communities and demonstrate their outcomes. So because when we think about, you know, small rural health improvement, you know, we want to have some improvement here. So when we look at the first one, you know, you read that and you see they're going to collect a number and percent that are currently reporting HCAHPS, you know, and again, that was a requirement. Everybody was supposed to. You had to be doing, you know, both of the HCAHPS and ICD-10. Now that has since been waived. And then the number and percent of SHIP hospitals maintaining or improving their performance. And then the percentage of survey completes for that SHIP hospital or for their SHIP hospitals participating. So when you think of the first one, and we look at this, we want the maintenance of 100% of hospitals publicly reporting as our final measurement. We want hospitals that qualify for star ratings, which was a great catch. Whoever wrote this one for that was, you know, looking at, you know, that star rating, because as we've seen on that first slide example, you may not qualify for star rating. So if they do that, they are 3 or above. And then increase SHIP hospital survey complete rate. So is there anything that you guys can see that you might suggest doing different to measure and look at data and available data to do this? Okay, silence. I'll call on you if you don't give me something.
Well, the increase in SHIP hospital survey complete rate does not have a quantitative goal.
Thank you. Yes. So, and that's, looking at your response rates. Now, with that, your complete rates, your response rate actually can come from your vendor, or the hospitals, as you know, can do HCAHPS on their own, especially if they're small numbers. But they can get this number quarterly from their vendor and, evaluate that. In fact, most of them get it real time. They can have month priors that in 2 months. So we know we can get that data and they can report that data. When we look at the outcomes, we want to demonstrate improving their performance in HCAHPS data. Keeping or increasing or maintaining that star rating of 3 or above. Again, I would look at very similarly, what was that pre and what is it post, in that year's time for capture and looking at that. All right, looking at the next one, the Qualtrics survey system for applications. Anything jump out at you guys with this one?
Are we looking at the one with the date 7/31/20?
Yes.
And so you're asking if we just see anything in that particular line that is sticking out to us?
Anything in those last 2 columns that says, yeah, this was measurable?
Well, it's numbers, it's a number completed.
Yep.
It doesn't say out of how many though. If that was the original goal, was just to do 2, then they completed 2. But what if the goal was to do 8?
Right. And what, and in my mind, okay, again, I come from quality. So when we think about quality improvement and we think about what am I doing with the data, just because I have 2 analysis reports created doesn't tell me I actually improved somewhere, because they can sit there just kind of like I call the CHNAs. It's, a fruition of effort, but we don't do anything with it. It just sits there and collects dust. What did they do with the analysis? That they had at least, 2 or 50% success on improving their project or improving an area of concern. And when we look at Qualtrics is a huge system. They have a lot of data, real-time data, to really enhance what we can do in this realm. And again, looking at, number of surveys created, well, you can survey people to death. If you have too many surveys, they're not going to fill out any single one of them. What was the value of that survey? Did we do it for patient experience? Did we do it for swing bed experience, outpatient? The OAS, the surgical side, looking at the CGCAHPS, looking at the provider side or PCMH, depending on what we're doing. Just because I have surveys created doesn't tell me that I actually have, improved in an area and done something with that. Why did they select that? And what is that, true, I guess I would say qualitative reasoning behind it, not just quantity and that quantitative too. I really want to understand that I made a difference with our hospitals in looking at that. Does that make sense to everybody?
Yeah, yes.
Anybody else have other thoughts? If you were writing this, would you change anything here? And how would you change them in either one of these?
Well, I think I would want to know the number of trainings first identified. So how many trainings did we identify we needed to do? And then how many of those did we complete?
And for me, I would like to know how many staff were involved in those trainings.
Okay,
You know,
right.
again, that's a numbers thing, but.
Right. Well, so for me, it's the number of hospitals too. So the number of people out of how many of our hospitals completed the survey or were trained.
Yep.
So, right. So how many trainings were identified? We needed to conduct 5, but we only got 2 done. And 15 people attended from 4 of our CAHs or 4 of our hospitals, and not necessarily our CAHs.
Correct. Thank you. Okay, we'll go to the next one, Andy. All right, here's another one. How could we measure this differently? If you look at that third bullet, really, the 4 hospitals are doing quality reporting data collection related training, but then really the HCAHPS focus, they are continued use of HCAHPS, reporting to hospital compare and or patient experience education. So this is their measurement. What do you feel could be measured differently? And for some of you, you're a little bit more seasoned, you'll see something different than, you know, our newbies that are like, hey, at least I'm getting data. You know, I've got something. And if we had 12 hospitals, and again, I don't know if this was a consortium or not, but we have 12 hospitals using SHIP funds for HCAHPS data collection and or related training. What could we collect from them to ensure that, you know, one, it'll support the vendor, but then let's look at, okay, what else can we do here as far as looking at, you know, our patient experience education. We created 4 new education packets regarding disease-specific areas. You know, what is it we created? And is it shareable to other hospitals in your state so people don't have to recreate the wheel? You know, that we can create, you know, some synergies with our hospitals as well. And looking at that. And then obviously, you know, one thing I tell people all the time is that send some of this stuff to Andy or Sally or one of the sources or the Flex team, you know, because they can share this on best practices. These are the great things that we do that we don't capture.
Well, so I think one of the things about HCAHPS is we do get, for our critical access hospitals anyway, not all of our small rural hospitals, but we do get the HCAHPS reports back to us so that we can kind of look and see, okay, where are we seeing improvement? But and so I'm open to this, but with the SHIP program, I really do, for HCAHPS, just focus on the number of surveys and the response rate, because if it's less than 100, it almost seems like it's insignificant, and yet it almost seems like it's insignificant because it doesn't show up on the star rating, but it is significant if we can talk about it on a federal level, that the way we report HCAHPS and the way we measure it for our small rural hospitals creates a disparity. So in that one, you know, I do look at the number of responses and the response rate. But then to also look really closely at that data to see, you know, of those 12 hospitals, which of those key areas do we need to have some training around to really bring them up or bring attention to them? So I think there is that training part missing from that as well.
I agree. And back when I had created Survey Solutions, and again, I just left that role this last summer, I fought with CMS about response rates in rural hospitals. And, Survey Solutions was created for rural hospitals to demonstrate the low volume data, and really looking at, hey, we need federal attention on this. Unfortunately, we're just low man on the totem pole because the financial considerations take precedence right now. So when we think about HCAHPS, we really want to demonstrate the quality of care. When we think about MB-QIP, and the reason it was created was to demonstrate the quality of care that our critical access hospitals are doing, back in 2011 when that came out. And so we want to demonstrate, look at what we're doing. We are 100% nurses communicating, but we also know in our CAHs, we tank in care transitions. We really did not do well in that scoring of HCAHPS. So how can we improve in those areas that were lower, not just in our response rates, because we're still collecting data. And I still think it's valuable data to look at, to really focus on what are we doing to make a difference. And that's where I think some of our SHIP funds could help in subject matter experts doing some training, coming in on site, or helping, their patient experience officer or whoever, even their middle management or upper management, to really understand how they could improve those areas. Looking at, some tools or programs that are out there that, have been vetted to be best practices as well, to really demonstrate the care they're getting, not just the number that they're getting back, and help that to shine. So I can go both ways. Trust me. I totally get what you're saying.
Well, and so with that, though, I think, again, it's because if we need to get the responses, we need to get the data in order to drive the decisions. And so I think a lot of education is just, why do we want the hospital staff to be engaged in HCAHPS? And we mean the entire hospital staff, from environmental services through, admissions through discharge. We want everyone to be involved with HCAHPS. And here's why. And then continuing that education to our public and our consumer, our patients, and saying, you know what, this is why it's not just a survey. We don't want you, it really is driving how we're going to provide patient care, not only today, but in the future. So I think a lot of that education is just, why is HCAHPS important? Why are we collecting this data, both within the hospital and outside of it?
Great feedback. Anybody else?
Yeah, this is Lori with the Indiana Hospital Association. Does it get too convoluted? I'm looking at the 4 hospitals will use SHIP funds for quality reporting data collection related training. Does it get convoluted if we made a measurement of like ran 2 PDSA cycles around the distribution of, the patient surveys? Is that too cross convolution?
So in my world, I say no. I say do it, because it really does demonstrate, those PDSA outcomes and what we're trying to demonstrate. And it either validates what we already know, or we have improved on, or it helps drive direction for the next year.
Right. This is a great example of a lean project. Like, this is lean at its best, using HCAHPS in that circle over and over, that PDSA over and over and over again. Exactly.
And it really kind of developing those champions, and, I tell people this all the time, rounding works. Collect your data when you're rounding and capture some of that so you can start getting the patients used to answering questions. At discharge, remind them, give them a bright colored sheet saying, hey, you're going to get a survey in the mail. It's going to have our logo, please fill that out. And here's why. This is what it does for us, and give 5 little bullets, and it can be just a half sheet of paper, an index card, anything. It could be a magnet that they put on their refrigerator. Remember to fill out the survey. And this is why we want you to do that. Looking at that, and then, discharge follow-up, transitional care management. Did I call them 2 days post-op or post-discharge? Did they fill their meds? Did they make their doctor's appointment? Do they understand their discharge instructions? And hey, you're going to get a survey. And then talk to their vendors. How quickly are the surveys going out? Is it within the next 2 weeks of post-discharge, or is it a month post-discharge? Because technically they have time to do that. They have 21 days, up to 42. So, hey, tap them and say, I need my vendor to do it sooner. So my money is going to be used to enhance my platform to get my vendor, my patient list to send those surveys sooner, you know, to enhance my response rate. Does that help you guys some on looking at ways to look at this? All right, let's go to the next one and see what, I don't remember what I have. Consortium. Okay, so if we do a consortium, what does it really look like? You know, it's not necessarily just the quantity of employees trained. Think demonstrated quality of care in a consortium and how to capture that data and what do we want to do with that data. And the next slide, we do have one of our groups has a consortium training. And again, looking at, you know, what they have, you know, and they built this under value-based purchasing, obviously, HCAHPS medicine communication. You know, there's 15 participants, you know, and they did one in December and one in January. I love that. I love that it's broken out. We have our time frames. We have how many are participating. And then we look at, you know, those measures. You know, participants gained an understanding of the language and nuances of the medicine communication and discharge communication domains. But what does that really mean? Did they have a pre-post test? You know, what did we demonstrate as enhanced from this? Participants shared the current process and investigated areas of opportunity through network collaboration to enhance performance. Okay, how are you measuring that? You know, yes, you've said you're going to do this with your consortium in your series of webinars, but how are you measuring that to truly demonstrate that you're making a difference? If you guys were to do those, then looking at those two, would you word them any differently?
Could you do
Yeah.
something like say they identified 2 areas of opportunity, list what they are,
Yep.
and then maybe, I don't know how
You
to
know,
finish that thought.
But, and we could have, you know, we identified these 2 areas of opportunity. And of all of our participants, our baseline scores were this. And then this will continue into next year's SHIP, or we know at the end of this SHIP year, our vendors reported we made a difference here. This is what we've done, you know, in success. Or we created 2 best practices as evidenced by this is going in their discharge packets. We're doing follow-up phone calls, you know, looking at ways to truly make a difference and capture some data. I just struggle with how are you going to demonstrate that in your measurement, your outcome, you know, looking at it as it's written now. The next one, I think, you know, I honestly like it. Improve the patient discharge process with assistance from the HCAHPS score. So we're monitoring, we have a baseline and we're improving the number of hospitals transmitting data. So we're getting data reported, you know, but then, you know, we're looking at that 91% score on the experience of care for communication about discharge information. So we have a goal in mind. So we have a baseline and, you know, then we have that goal in mind of where we want to get, you know, and looking at it that way. And comparing first and second quarter of HCAHPS submissions for fiscal year 20. So again, it demonstrates some baselines. But, you know, if we're looking at first and second quarters of fiscal year 20, you know, that really doesn't give us a whole lot of time to really demonstrate the improvement. It will have to probably continue into that next year to continue on looking at what we could do different. And I like the 3 out of 17 saw an improvement. Any other thoughts on those? All right, next one. Here's another one, a little harder to read on my screen anyways, because I've got my little surface in front of me right now. But I do like this, and I like some of the timelines that have been demonstrated on it. here's some of the assessment is being done initially, and then they're going to start doing some data capture, the outcome and the deliverable. Here's where I get a little hung up. I like the fact that you're creating a comprehensive toolkit with resources to guide the hospital improvement. It's the same deliverable for everyone, which I'm a little, I would have liked to have seen something different for those. But how are you going to measure that? Are you going to have 2 toolkits created, 1 toolkit, 3 toolkits? What does that really look like? When we start thinking about our data, we have to data mine this too, and shared resources, how many of these shared resources are actually created? Anybody else have any thoughts on that? How are we going to demonstrate on our outcome or our impact and improve patient experience process? Number of coaching encounters, number of action plan items implemented, and then really looking at that process. How do you capture that process, with our staff, especially to really enhance that patient experience? So when you start creating these, or you have a vendor or a subcontractor that's doing some of these consortium work, really kind of challenge them to have data. I don't want just words as a report. I do want some data, and how are they measuring that data, to really help along the way. First quarter, we're going to look at 2 areas. Second quarter, we're going to look at another 2 areas. Third quarter, we're going to revisit the things we implemented in first quarter, to enhance what we have done, and solidifying that the work is being, kind of ground in and, part of their daily work habits, looking at it that way.
So Angie, that's Sally, for the outcome or impact. For instance, in in this second row of the conducting the training meetings regionally and statewide, and it looks like progress measures are will be robust. But then if there was that they're going to increase hospital capacity by 25%, that they're setting, again, if this was the work plan being submitted, they haven't collected the measure yet, but having a sense of how much of an increase are you trying to get, I think shows not only a 4HP that you have a sense of the baseline or where you're going, but also for yourself of them when you go to report that a year later, you can say, oh yeah, we have 30 hospitals and we wanted 90% of those to have participated, and to share a best practice with each other or something.
Good call on that. Thank you. And in my mind, I would almost use building hospital capacity in a small improvement project versus using this for that reason, looking at it a little bit differently, as an innovative project. But again, we're building patient-family experience, and the better our outcomes that we share and are very transparent to our community on what we're doing, word of mouth spreads, and we all know it. I tell one person, they're going to tell 11, and those 11 are going to tell another 11 more each. It grows. So again, looking at, okay, what are we doing to increase hospital capacity, but also, it's through our marketing strategy and how we're doing that and how we're building on that through these action plans. And what is our baseline? Why did we select this to begin with? Were we having a problem? Is this something when we sent out our survey to all of our SHIP awardees saying, hey, what are some of your challenges that, give us some ideas? And this is what they had asked for, looking at that. And again, when we go through the one-on-one calls, we can dig a little bit deeper on some of these as well. Just want to give you guys some ideas of where my head is going and where I think you can, look at some ways to improve on the data, because there's no data here. And, again, data analysis, how do you demonstrate that you improved? I can tell you, I trained 100% of my staff. Did they retain it? Did they do anything with it? Did it make a difference? That's, it doesn't tell me anything. Next slide. Okay, enough about HCAHPS. Value-based purchasing, reporting options, data capture. Again, if you use the toolkit, it takes you to this, and there's areas that we can get data. Again, it still says hospital compare, but that's changing. And looking at some scenario data key points. There is challenges with current data, and we know that. And value-based purchasing and ACO are going to kind of blend together. Some of this overlaps with our HCAHPS, obviously, because it falls into this as well. And then really looking at what's our baseline? What is the baseline of immunization? Last year, I was 85% success of getting all of my staff vaccinated. This year, my goal is this. So how am I going to do that? Looking at antibiotic stewardship, and I know we touched on this a little bit last time. What is it that I need to work on in my antibiotic stewardship to enhance the quality of care that we are doing? Reducing readmissions, that is a data report, but that isn't necessarily a game stopper because we can get data from our hospitals and they have it accessible to them. They know when their patients are being readmitted and they can submit some of that data. Again, if you give them a portal or a way to report it, it's, a lot easier to do. And then, really, kind of digging into some of these scenarios as we go along. So we'll go to the next slide. So let's start breaking some of these down. This one is looking at related initiatives with value-based purchasing. The number and percent of SHIP hospitals utilizing incident management data and software for quality improvement initiatives. So that's what we're gleaning from this. So let's say we have 10 hospitals of our 40 that are eligible, or of our hospitals. So, we have a very somewhat low number, 40% maybe, using the system, using software for quality improvement initiatives. Just because they have the software doesn't necessarily make us aware that they actually made a difference. So yes, we want to maintain that 100% SHIP hospitals utilization of the software, but target specific quality improvement interventions. How many? What is that number? What is it? What are we looking for with this? Because quality improvement training is huge in the utilization of our SHIP grants and what they're meant for. So what could we say if we wanted to change that a little bit different?
Angie, can I ask a question?
Yeah.
When you're talking about putting qualitative information in here, you're talking about the work plan that you submit, not just the one where you're reporting on what you did the previous year, correct?
Correct.
So you're just gonna kind of make up a goal, and that's what would go in there?
Well, you should do a pre-assessment every year with all of your hospitals saying, what are your challenges? So we had 50% of our hospitals had no software or incident management data. So our goal is to get 90% of those 50 participating in this. We have some ways of capturing some data and getting them to use it. But then just because they have the software doesn't mean they're actually using it for, as this one says, specific quality improvement interventions. So looking at what kind of interventions are we looking to do with this software? What is it we want them to utilize it for? Does that make sense?
Yeah, and then I'm just wondering, because I've worked on Flex and SHIP for many years, but doing so we're the subcontractor to the Office of Rural Health. Yep. So I've always done the projects. I've never done like the grant reporting side, and we've had some turnover in our office. So I am an absolute newbie at this.
This is good.
Are there like instructions in everywhere? Because I mean, when I first looked at it, this year was the first time. I said, what is a process measure? What's the definition of what they want as the outcome in here? Are there instructions somewhere that I'm missing?
Sally's going to talk.
Okay.
we can put it here in the chat. Is there a performance management guide and evaluation guide that was created for SHIP Aha, yeah.
Is it this?
Mm.
Okay. I just found this the other day. I haven't looked at it yet, though.
Okay, that has some, good definitions that are, in terms of match to, for the SHIP program of the work plans and what FOHP is looking for in the work plans in their annual report. So that helps kind of tease out, output or progress versus outcome measures, Becky.
Okay, perfect. Thank you. That's what I was looking for because, in the past, I've had people just say, okay, tell me how many webinars did you do? How many people attended? Those kind of things. But I wasn't the one actually creating the work plan stuff and the measures and things like that.
Yeah, and that made me think too, many states are using SurveyMonkey for their annual SHIP application and to get not only a sense of what do they, if they're not in a consortium, or even if they are and they have to narrow down, here's your 4 choices of what they're selecting for the coming SHIP year, but what's your progress, what was achieved. So in SurveyMonkey, that might be an opportunity to add a few questions of the training, did you implement the knowledge gained in this case, incident management, on a scale of 1 to 5 or something. Or if you have 80 hospitals and they're spending it differently, you might have to write those questions, not to a specific topic or even category in SHIP, but at least that of the training or software, did that help improve their value-based purchasing measures or reporting, so that hospital application is a template, but that could be a tool to gather feedback, as well as Angie said, having a pre-post test on the actual trainings to capture knowledge gain, but to know, did they implement that knowledge or those recommendations into a process improvement.
Anybody else use SurveyMonkey to capture data?
This is Sherry from Texas. We use job forms on our application forms and then also on our project completion forms. And that's where we gather all the data that we collect.
Good. And then you get to filter through it, correct?
Well, it then transfers over. Yeah, then it transfers over. You can get it into Excel, and that's where I do all the analysis.
Yep. I love Excel. It just does everything.
Because we recognize that in the States, you have maybe raw and BQIP HCAHPS data you're receiving for the CAHPS, but then for your PPS, you have to go into hospital compare, and it's scrubbed. Is that the right term, Angie? So, there's especially in Texas, you have a number of PPS hospitals. It's not easy. So, we're just trying to help you look at. It may not be a measure you can get into that raw HCAHPS and say, well, we increased outpatient 21 measure by 10%, because that isn't, you're not able to get good raw data. However, look at ways that you can be looking at their level of implementation.
And again, when we do the one-on-ones, we'll dig into everybody's questions. So write some of these questions down to ask when we talk as well, because that's what this is for. It's to help everybody to, really grow in this and grow in knowledge and, be the best of the best in your SHIP grants. So next slide. All right, here's 2 more. And these were a little bit more interesting. So when you read them, they were both value-based purchasing related initiatives. Reporting measure is completion of an efficiency or quality improvement training project, or completion of provider-based clinic quality measure training. What would you guys write differently if you were going to collect some data? We've been talking about these for that first one, completion of an efficiency or quality improvement training or project. And here's why I'm going to frame it differently. As the SHIP coordinator, one of the things I used to look for, what type of projects were they doing? And the reason I wanted to know what type of efficiency or quality improvement project was done was, will that enhance somebody else's in the future? You know, so I can say, I had these 4 hospitals do this project. They did it, you know, 2 of them did it together and 2 did it siloed by themselves. But then we have a robust toolkit to produce for other hospitals to utilize, or we now have a best practice to use, you know, in this quality improvement training and whatever it was related to, you know, to share. And again, when we start looking at the following year, we've now enhanced it by engaging 4 more hospitals, you know, to utilize this best practice. How about the provider-based training? Anybody see anything jump out?
Well, I think this is when it goes back to the assessment. So we did use SurveyMonkey to conduct our assessment, and within the assessment then, you know, what were the areas that the hospital specifically wanted to work on? So is it cybersecurity training? Is it pharmacy? Is it community paramedicine? And so on the one that's on the left, the 4 hospitals will use SHIP. I think that's when I would specifically identify we're going to use the SHIP funds for cybersecurity training for all 4 of them. On the right, let me go back to the one on the left. Really, though, patient engagement came back really high, so that would be maybe more. Cybersecurity, though, is where we're going. Anyway, on the one on the right, I'd have to look at what the provider-based, what the measures are, but again, being really specific. This is the very specific activity that's allowed within the SHIP grant for this category, and this is what we're going to do. So there's very specific activities. Pharmacy is one of them. Telehealth is one of them, right? So of that, which one specifically are you guys going to work on, and how are you going to do that? And we do a lot around lean. I'm going to bring up lean again. And so one of the things that we just discovered in our assessment is that they are not using this information for decision making. So, you know, this is great data for those lean projects that we're starting to work on, but let's really identify what project we're working on and really work on it.
Yep.
Angie,
And
this is
this
is Danette Swanson. I'm just wondering, in these situations like this with the training, is anybody doing pre-training tests and post-training tests to measure the knowledge gained?
Excellent question.
Yeah, great question.
I mean,
the other one is how many people participated. And then
and you can show a percentage of with the number of people that participated and the number of people that showed improvement of knowledge, you can show some percentages there too.
You know, and in my mind, again, thinking, I think provider-based clinic measures, your MIPS quality scores, things like that. Okay, how many quality measures did we cover? How many staff were covered in the training? And then did we pick 1 or 2 to actually make an improvement on? And what did we do with that? You know, did we have a pre-post, you know, implementation? Or, you know, in Kyle's defense, you know, because I love lean, you know, did we start 3 lean projects based on the training? You know, what was that outcome? You know, just because I did the training is, you know, irrelevant, because, you know, doctors will go, and staff will go through training all day long. Doesn't mean they did anything with it or retained it by any means, changed the way they practice or anything like that. So again, we have to look at what did we do with this data? To me, they're still incomplete when we think about how we have written this in our work plan, and it just doesn't give me enough, you know, to do something with. The next slide. So this is one, and this is totally example. This isn't a consortium example. This is one that I had written back in the day at ICANN. These are out on the website under the toolkit for resources. This one is in regards to, it's a value-based purchasing in, I don't remember, sepsis certification. And what we're gonna do, how many hospitals were contributing and pooling funds, what were we gonna look at, and then what were some of our objectives. And then as it goes down, it says, here's our date, here's our agenda and details of every single training. And then we looked at how we quantified that with data. You know, how much data did we implement? You know, what did we use it for? How many trainings, how many sepsis toolkits were created, you know, and then we started looking at, okay, we found out that our patients weren't getting identified as a potential sepsis risk early on. So this is what we did to prevent that, you know, and we submitted, you know, and we started tracking that. So it's just an example of how we kind of wrote some of it as the SHIP grant coordinator to track and trend. So we'll go to the next slide. I think the next one's a consortium one as well. Yep. So here's another one in looking at some consortium projects for the value-based purchasing programs. And again, the first one reads, you know, that 12 applicants selecting HCAHPS collection and training. And then facilities should improve, and I'm reading off the right-hand column, you know, related outcomes, quality related outcomes. Well, how many outcomes? What were you looking at? Again, are you guys starting to see a pattern here of what we're looking for in looking at assistance and training of whoever was providing it, that technical assistance moving forward? And then, you know, what was that true consortium group and the outcome of what they had completed? You know, again, when you start working with, you know, the consortium projects, really think bigger, you know, and, you know, what are they going to glean from this, whether a CAH or a PPS, you know, it doesn't matter. We're really wanting to evaluate the effectiveness of the training that was offered and the implementation of some potential best practices moving forward, and that they made a difference, you know, that we really looked at our data. Looking at our readmission data, 4 of the 17 hospitals have had one-on-one deep dive training regarding quality performance outcomes, regarding, I'm assuming, readmissions, but it doesn't tell me that their readmission rate was 12%, national standard is 8%, and this is where they're at. It didn't give me any data to say we made a difference or we didn't make a difference. Some of that pre-data versus post-data. Anybody else see anything that jumps out at them? You know, on that last one, looking at the end of year 2, activity to receive hospital-specific HCAHPS reports, 17 hospitals received performance reports. Well, they all received performance reports. So we all get that in HCAHPS. What did we do with that data? You know, how did we change it and, you know, improve? Next slide. All right, let's get into some ACOs. So value-based purchasing, ACOs, they kind of blend together, but they don't. And a lot of people don't really understand all the data that's available, because there is a plethora of data available if you have hospitals that have used this for ACOs. And like I said last week, a lot of times when they're using their ACO funds, it's to be a member of the ACO. They can range in a lot of pricing, and this just kind of helps soften that. You know, so looking at what are they doing, and as an ACO, they're typically working collectively and collaboratively together. So I wanted to kind of go over some things. And again, in Illinois, you're going to see Illinois examples because that's what I have available. What we have at our fingertips that we can report. And again, you can use SurveyMonkey for your reporting structure to collect some pre-post data, you know, looking at trends over time and how you can improve and demonstrate improvement by being in this ACO or shared savings program. So this one, these are ACO quality measures. The ACO, we are required to report on these measures once a year. Most times, data is collected somewhere around October, is when they start collecting a lot of this data for the year prior. So you'll see influenza immunizations of our Medicare patients or whatever, you know, we also were part of a Blue Cross Blue Shield ACO, tobacco screening, colorectal cancer screening, breast cancer screening. And these are all the same that can be in your physician measures, but it gives you data, which, you know, is what we're looking for. It just gives you data. You know, next slide. This one is an example of a scorecard. And again, I took all the data out, so it's all red right now. It turns red, yellow, green, depending on your number. But it showed all of our hospitals that were in the ACO had to report quarterly on their performance. So we had Medicare well visits, you know, post-discharge follow-up calls. That's our TCM opportunities. That's also a chance to improve our HCAHPS data, you know, by getting those survey reports back. You know, our transition of care follow-up, really starting to enhance that. The ER PCP alignment, that they were coming into, quit using our ER all the time. Looking at ER telephone phone calls, you know, to follow up and make sure that they did what they were supposed to post-ER. And then referral tracking completion was another one that we had done. And then we started looking at some skilled care trackers, patients to swing, patients to nursing home, which are just some quality measures that we were looking at. And then remember last week we talked a little bit about disease registries. Here were some that we were requiring our participants to do: diabetes, COPD, CHFR, and hypertension. You know, the four main ones that everybody sees. You know, start developing your disease registries and then acting on that. That we had, you know, 3 education pieces to send to our patients with diabetes. You know, that they were getting their A1Cs followed up on, that they were getting their weights and salt intake under control, you know, with their CHFers and the COPD exacerbations. So next one. And then again, ACO quality reporting, they get this every year. A lot of times they will get it from their vendor. We had eClinicalWorks, and then we had Cerner as our ACO platform. They give this data quarterly, so you can have access to it. It's no additional reporting for anybody because you can just ask for it from their ACO participation. They get these reports. And then start looking at, okay, we made a difference here, we made a difference here, you know, and start building on that. You know, and again, it just gives you an overall global picture of what the ACO reporting looks like and some of the data that it tracks. So when they select those ACOs, next one. Again, there's a CAHPS survey. Last year it was waived, so we didn't do it. I can tell you some of those areas are still low. Looking at health promotion and education, shared decision-making, stewardships of patient resources, those tend to fall low in all ACOs. You know, so really kind of enhancing some of that. If we look at patient safety, patient fall screenings are one of them that should be done. You know, again, these are measures that we can do very easily with the CHIP funds for ACO participation in a quality improvement project. And you can ask them, what kinds of information is your ACO collecting? And you should see some of this. Next slide. And then here's a consortium, ACO starter is what I tried to kind of come up with. You could pick like one that, you know, these are 6 possible goals you could select from, and a reporting. And here's your reporting time frame, you know, to look at that and how they're participating. And again, it's just a guidance, you know, for when you are looking at some of this metrics and how you can enhance root cause analysis. Are you doing any kind of RCAs on anything, on your readmissions, on your swing beds, you know, looking at what can we do differently? Next one. Whoop, I lost it. There we go. So here's one of our hospitals, or one of our state offices in the SHIP. So these were for the ACO and the Health Information Technology, the HIT part, improvement in hospital staff expertise, understanding competencies in the areas of HIT. So and here's your cybersecurity, and I thought decrease in hospital cybersecurity vulnerabilities. You know, so did we know how many we had pre versus post? Again, looking at, you know, did we make a difference in this? And then increasing awareness, how many people were trained, and looking at, you know, how many secret spy stuff did we send out if we use like KnowBe4? How many people actually opened those emails, you know, and really kind of help enhance the product and the awareness when we look at this. Anybody else see anything that jumps out at them on this one? The other one, improvement in hospital staff expertise, understanding and competency in the area of quality improvement. Again, what kinds of QI and, training did we do? How many participated? How many frameworks were implemented using that understanding and that knowledge, to make that difference? So, to really enhance that shared savings investment. So, next slide. All right, here's a couple more for us. So, and these were the ACO investment activities. Only one selected doing the computer provider or CPOE, physician order entry. 6 used it for pharmacy services.
Right, Angie.
Yeah.
So when I'm looking at this compared to what we looked at before, where it just said value-based purchasing or whatever, this one is more specific. They're going to use it for order entry. They're going to use it for pharmacy. They're going to use it for disease registry. Yeah. So
yeah, and you're right. It does give us some more specificity to what the dollars are being used for. Now, with the disease registry services, I'd really like to know how many disease registries were built by those 2 hospitals and maintained throughout the course of the year, just because I want to know if it makes a difference.
Right.
Did we help those patients? And looking at completion of efficiency or quality improvement training related to ACO or shared savings initiatives. I'd kind of like to know, what they did with that. But again, if they are part of a shared savings program or an ACO, they have all that right at their fingertips. So it's not extra reporting, it's already being done. So we can look at that. The 12 doing telemedicine, that's a great one as a consortium too, really looking at how did they build it, what did they build, who did they use, and really enhancing the rest of the state from that experience. So, and then obviously cybersecurity, utilization of cybersecurity services.
Angie, on the telehealth, on the telemedicine or mobile health, would you want to see something like an increase in the number of encounters using telehealth? I mean, would you want to try and
so in my mind, yes, I would like to know, when it was implemented and how many encounters per, or were you using it for specialty services? Especially during COVID, telehealth was huge. That is the best way to really enhance the care you provide through telemedicine and make sure that those patients aren't going, under the rug and being forgotten, that we can really enhance their medical experience, through telemedicine. So how much equipment did we install? How many patients were seen? How many people were trained in that? What were some of the hours offered, that we had, the other piece of that, it will show revenue too for that hospital. And when we think back to the other one, when we're trying to get, capacity, it doesn't build capacity, but it enhances us as provider of choice, but it also gives us some revenue as well. Next one. Okay. So the next several slides, these are not my slides. And the reason I'm sharing them is I just thought it was good. A lot of times as SHIP coordinators, we don't come from healthcare background, or we don't understand things. And I don't know when they offered this or when they presented it, but I always liked, the presentation. So I had kept some of this from them, and it was Lisa and Kimberly. I don't know which one talked on this or anything. And like I said, I don't remember where they're from, but it's just good stuff. And it's looking at some of those financial impacts as, we just talked about too. So next slide. All right, so successful value-based purchasing programs, they really require good education and understanding of what they are. Your quality programs, obviously your patient engagement, and it's not just patient engagement in satisfaction, and doing a survey. It truly is your chronic care coaching. Motivational interviewing is huge. I highly encourage, looking at other ways to engage our patients, and really get out of them what their concerns are. Coding, and you're going to see coding here in a minute, a little bit further, and then wellness and prevention. So when you're starting to see these hospitals say, hey, I want to do this or I want to do this, here's some areas you can give them suggestions for next year even, of here's some thoughts and topics that we could start covering as consortium work. Next slide. So really looking at risk and risk adjustment, that's that predictive analysis tool, and it looks at claims data and how they determine the payment, and looking at that risk adjusted score. This is mostly for your ACOs, but they are going to know their risk adjusted score. And while right now it's not making a big impact because of COVID, there still is profitability or the potential of loss in future years as we continue to move forward. Next slide. And then here's some education. Again, really start thinking about, okay, if we're going to do some value-based purchasing training, what could it be? Really looking at accurate coding, the calculations, our patient acuity, are we, scoring them correctly in our emergency rooms? What kinds of payers are we, working with to adjust some contracts? And it really kind of leveling that playing field with all of our payers and our payer mixes in the rural sectors. Next slide. And then again, looking at more, and this just gives you some ideas of where you can gather and glean to engage your hospitals, to move forward. Next one. All right, and this is just an example, and this really is looking at what our patients have and where we need to enhance the coding, the capabilities, and what we're capturing with this patient and that assessment and plan. And again, this is, chronic disease, in its finest. So next slide. So again, looking at some, documentation and coding, risk adjustment really pays, and you can see the difference, in these two people, what we've done, and look at the payment difference of the annual payments that we could have gotten. And if you're in an ACO, they look at this. So when you see people using ACO data, it financially, there is money to be had, and, just to kind of hang on to some of that. So next one. So, and again, 4 keys to improving, really looking at ways to measure this, mastering compliance with the quality measure reporting, and getting them to report, but looking at the inefficient spending. And these are great consortium projects. They're great one-on-one projects with some consultants, to assist them. And then delivering exceptional customer service. Really look at some of those customer service programs. Michelle Rathman-Bashke, I know, has one. Joe Tai has one. Brian Lee has one. There's multiple programs. Studer is another one, if they are using Studer, or are they Studer-like, and again, really enhancing that customer service experience. So next slide. I think that's about it. Yes. Woohoo! We got done early today, so we can actually talk and ask any questions that you guys might have. So this is questions, comments, and thoughts. This is your open mic time, thinking about data and where you're getting data and how you're getting it. And then what I really want you to think about on our one-to-one calls is, how can I capture data from these hospitals? So you can see some of the ACO metrics, shared savings programs, they have data there and they're already measuring it. So ask them to pick a point, especially if it's a single hospital, ask them to say, hey, I want to do this or I want to do that. So you have something to capture and quantify in your report, to demonstrate what a difference the SHIP grants made. And that's really what we want to enhance, is these SHIP grants make a difference to our hospitals, whether it's individual, it's consortium work. Yeah, I will be honest. I had 4 hospitals in Illinois say, I'm not going to participate because I don't want to have to report any data. I said, okay, how about I do some of the data capture for you, and we made it easier so that they can actually use the funds and participate. And participating in consortiums was so much easier for them than doing single individual objectives moving forward. So there's ways around it. And I really want you guys to embrace, getting everybody engaged and, getting the money and utilizing it. And if you really don't want it, would you donate it back for a project, and looking at how we can do, a shared project. Questions, thoughts, ideas, thinking about data.
I'd be interested to hear a little bit more on, you talked about doing an assessment, and then also there's the hospital application form. So are we talking about two different items that are sent to the hospitals? I heard someone else talk about a final feedback form as well. Is that part of like the reimbursement request? I'm just curious to hear more along those touch points with the hospitals, above and beyond even, asking for quarterly data or things like that.
So I'll let some of it, you guys talk first, and then I can share what we've done in the past.
Nicole, this is Sherry from Texas. So if you were referring to what I'd said about our project completion report, that's in reference to, so after the hospitals have finished their projects, that is our reimbursement mechanism that we use.
Okay, thank you.
Anybody else? Anybody do a pre-assessment
I would just second Nicole's request for more information on that. I would like that too.
Okay. Anybody out there do a pre-assessment of ideas, needs, that they could share that survey that they use to put out to their hospitals when you're getting ready to create your SHIP work plan?
See, I think we do it very informally in group meetings and not in a formal way that helps us quantify anything.
Okay. Anybody do anything different? Anybody else want more information? Do we want to kind of do another little training on that of possibilities?
I'd be interested.
Yes.
Okay.
Yes, I would be interested in doing that.
Okay. And Sally, do you have a best practice out there of anybody that does that now? I mean, I can ask Brian from Illinois, but you might have somebody else that does some of those assessments. And anybody else?
Sorry, I'm on mute here. I'll confirm with Andy and Matt, because Andy keeps track of those who might have incorporated that in their SurveyMonkey as well.
Yep.
I'm also
Perfect.
trying to remember if there's one that's more of a pre-assessment in the performance management guide.
And then your final project completions, you know, your wrap up will help guide you for the following year. Which is nice.
This is Joyce from Indiana, and we do utilize SurveyMonkey as a part of our hospital application, and we offer 4 different projects that the hospitals can choose from each grant cycle. So we have them rank them by their level of interest and create our cohorts for each project based upon that level of interest. And then when each project leader meets individually with the hospital, they then customize it further by what is the actual need that they have.
Okay.
So like if one of them is a simulation project where they come on site and they'll ask them, they do 2 simulations. What are your areas that you feel like your quality improvement needs to focus on? Is it sepsis? Is it prenatal emergencies? What is it? And they create the project around that need.
Nice.
So Joyce, your office identifies 4 main priority areas. And so do you use that hospital application form then, or do you use your own version of that during the NCC?
We modify the template. So we add that question to our application through SurveyMonkey. So we identified when we began this transition in our SHIP program from basically being money distributed directly to the hospitals to more of an education training program. We identified 4 programs that we would offer each grant cycle. Like one is patient family experience, the second being maximizing reimbursement outpatient setting, the third is simulation, and the fourth is mental health with a focus on zero suicide. So every grant cycle, we offer those to all of our SHIP hospitals, and each grant cycle on their hospital application, they rank their interest in what they want to do that grant cycle. So our goal was at the end of the 4-year grant cycle, hospitals would have participated in each one of them. Now, I will share with you, this year we did change it up a little bit. We offered them the opportunity to go back and do last year's if they wanted to because of COVID. Many hospitals really were not obviously able to make that full level of commitment to the project when COVID erupted. So we did, revamp it a little bit, but that's our overall intent.
Awesome.
This is Sherry from Texas. What I find out from what we kind of find out is that their needs change so rapidly. I mean, we can do an informal assessment, say in November, in the fall, and by the time we're ready to implement, they're really looking at, they need something else even more. So that's a difficulty I have with the 120 hospitals.
Yeah, and that is a challenge. And I've seen that in several states as well, where, come February, in March, you're changing up what their original application was for because of changes that have happened. Anybody else?
We've just been able to continue on a yearly basis, building on what we've done in the past. And I've managed the SHIP for 10 years, and we started out with meaningful use, and it just seems like every year we hit the immediate need or situation that was going on with all the hospitals. So we went from meaningful use, we went to and then they were able to buy equipment or software that they needed for their EMRs, or then we went on to ICD-9, transition to ICD-10, and then from ICD-10, it was a really big opportunity to explore the revenue cycle. So we did revenue cycle workflow analysis and process mapping. And that was a huge eye opener. We did that for 2 years. We changed up the training in the second year a little bit. And then from doing that 2 years, we had a really big aha moment showing everybody that there was a greater need for training in the registration and admissions area, because having that area being entry-level position and people not understanding what happens in coding and billing, there was a big opportunity for additional training to be done so those people can also help and enhance the coding and billing part of the revenue cycle. And then from that, we also did another grant where we were doing user group, EHR user groups. And from the EHR user groups, we had an ongoing issue when people, whatever people were talking about with their EHR, my question back would be, have you done any EHR workflow analysis? And that was such a big issue that we chose that as something to do through SHIP. So just working with the hospitals each year, paying attention to what they're doing or what's going on or what's happening in the workshops this year may lead to something we do next year or the next, maybe next 2 years or something like that. So we keep on working on what we're doing, paying attention, and then building on that and moving on to the next idea that makes sense to continue progress.
I like that. Anybody else? So I'll talk with Sally and Andy and Matt and see how we can do a little bit of extra training next time that we're on. But again, I know we're getting close to 1 minute left. Wrapping up here, schedule some one-on-one calls over the next week with each of you. Have some questions ready. I'll ask you some questions as well. If you haven't sent your work plan in, please submit your work plan. We can go through that or the challenges you're currently facing. And then we're going to kind of bring it all together at that last session. Was this helpful for everybody today, kind of going through some of this data? I see some heads
Yes.
nodding. So,
Oh, absolutely. Yeah.
you know, I don't want to go overly deep, but I want to be deep enough for us that are seasoned that we're getting something new. So, and if there's anything else in any of this that you guys want, hey, give me a shout. I will gladly send you what I know, or we'll talk about it just one-on-one. So that's what I'm here for. So, all right, so you're going to see, Andy, how are we going to do the one-on-ones? Am I going to just send out emails to everybody?
Yeah, we can follow up, Angie, and we'll send out information to the group. And people can just follow up from there.
Perfect. So, well, I am looking forward to our chatting. So hopefully you guys enjoyed this today and giving you a little bit more of some ideas of things to do, and have a wonderful rest of your week. So thank you all.
Thank you.
Thanks, everyone.
Thanks, Angie. Thanks, Andy.
Thanks, Angie.
Thanks,
Bye.
Sally.
Bye all.